Those of us here at Colorado State University are proud to share with you this session of Endoscopy Talks. When you're looking for inspiring veterinary CE experiences, think CSU Vet CE. Nestled up against the Rocky Mountains in our new State of the Future facility, we invite you to experience what we call CE Elevated. We'd love to see you in one of our future on-site, online, or blended courses. Check us out at www.csuvetse.com. Now, please enjoy Endoscopy Talks.
Hello, everyone. Welcome to Endoscopy Talks. I'm Dave Tweed here at Colorado State University, and I'd like to thank you for joining us on behalf of Colorado State University's Translational Medicine Institute, also known as the TMI. So today we're joined by Dean Hendrickson. Dean is a colleague and a professor at Colorado State University in the Department of Clinical Sciences. He's a boarded in surgery and an ACVS founding fellow in minimally invasive surgery. That's large animal soft tissue surgery. I can attest that he is an outstanding equine surgeon, but today he's going to diverge a bit and talk about another one of his interests, which is performing minimally invasive surgery on large exotic and wild animals. Dean will tell us about the opportunities and challenges involved in this area. So without further delay, I'll turn the session over to Dean.
Thank you, Dr. Tweed. It is a pleasure to be part of this today. Grateful to have the opportunity to join you all. So one of the things I'd like to do is just really tell you a little bit about my experiences in minimally invasive surgery in large, exotic, and wild animals. I think probably the big thing as we touch into this is recognizing that the large exotic animal surgery takes a team of people. There's no question about that. And we as surgeons offer a small piece of the puzzle here, but I think hopefully we offer a valuable part of doing these procedures. There's really, at the end of the day, it's translating what we know in the species we typically work on to work in these other species. And I think that's probably the biggest encouragement I give people who ask about how I got here is, I think maybe if anything, I'm a good translator. And that's the goal. And I think really one of the fun parts is it takes you places you'd never imagined going. So let's look at it from the beginning. And for me, really, this all started with Pokey the white rhino. And Pokey is a rhinoceros, or was a rhinoceros, and the fossil rim down in Glen Rose, Texas. And she had a uterine mass, and they wanted to do a uterine biopsy. I asked them why they didn't just go through the cervix, and they sent me this photo of an ultrasound showing the very cartilaginous and tortuous cervix that rhinos have. And they said the problem is it doesn't really work to try to go through the cervix. So we want to try to do a laparoscopic procedure, and we'd like to do it standing. So we'd like to do standing laparoscopy, and we know that you like to do standing laparoscopy in horses, so we'd like for you to help. And I said, sure, let's do that. And they said, well, how are you going to do it? They said, come up with a few plans. So I came up with two. Plan A was to do the surgery like Pokey was a horse, and plan B was to do the surgery like Pokey was a rhino. Not very creative, I guess, but at the end of the day, I really didn't have a lot more to go from. So I asked for some photos. Let's see what Pokey looks like and get some measurements to help. And so they sent these, and the first thing I looked at is that this is the flank area where I really want to put my portals, and they've got this extra fold of skin in this white rhino, and that's going to be a bit of a challenge. So that was interesting to look at. Look a little bit closer here. We've got what look to be ribs in these areas, and so it comes back quite a ways. We've got this big fold of skin. Thought, well, that's going to be challenging. Hopefully I can go in front of this fold of skin, because going behind looks like it's going to be a real problem because that's where the leg is. And they sent some measurements so I could get some idea of depth that we are going to have to work in. And you can see that Pokey's got a lot of girth, and 16 inches from the flank to the midline. And with this uterine horn mass on the right side, it could be moving over towards the midline because of its weight. And so we're looking at instrument length and cannula length and trying to make some decisions on what to do. So I did some research, talked to people who had done postmortem exams on rhinos and tried to get information on what to go through. And the big thing sounded like it was going to be thick skin and a heavy duty peritoneum. And so with that, we headed to Texas to have a look. And here we are working on Pokey. Now, Pokey was trained to come up to the side of the fence here, and it was a right-sided mass. So here I am brushing her, cleaning off her right side, getting things ready so that we're able to go in and look. And we had her turn around, and we're trying to use the ultrasound to see if we can identify the right areas to go. Now, the problem is rhinos have a very porous skin, and they get lots of dirt and stuff in it. So ultrasound was not terribly rewarding. But we did feel that we could make our approach just in front of that big fold of skin. Everything got ready. We made the plan. The next morning, we all gathered to talk about the final preparations, and we went to surgery with Pokey. So they did standing sedation, and Dr. Hodges and Dr. Zuba were responsible for doing the sedation in Pokey, and then we were responsible for doing the surgery. So here I am with a nice long Storrs cannula that we are trying to poke through, and we're trying Pokey with a fairly traditional approach of about a 2 centimeter, 3 centimeter incision in the skin, which happens to be just about 4 centimeters thick, and actually closer to 5 centimeters thick. And then we are going to go in through the muscle layers and through the peritoneum. And what you see here is me hitting peritoneum, and it's a little bit like hitting a wall. The cannula stopped. It wasn't going any further, and we're working on this. And so at this point, at this place where I'm pushing pretty much as hard as I can, realizing that just underneath the peritoneum is the cecum, and I really don't want to see the green of the cecum when I put the scope in. We were fortunate that didn't happen. So we got into the peritoneal cavity, and here we are. This was again, you're going to see a lot of specially designed Storrs equipment in this process. So we've got the long cannula here, regular equine cannula, which wouldn't quite get through the body wall, but it would get us at least close enough that we could do this. This gentleman back here was actually my protector, and I didn't realize that, but they had assigned him to watch over me. I'm a little protective of my instruments, and so when horses try to cause problems, I have a tendency to lean into them, keep them on their feet to protect the instruments. And at one point, Pokey went down on her front carpi, and I leaned into her to hold her up. And this guy grabbed me from my back and pulled me away and said, "They told me you'd do that. I just didn't believe anybody would be so crazy as to try to lift up a rhino." I guess I still need to protect my instruments, but we were successful. So with some challenges, we were able to visualize the peritoneal cavity. We got some nice looks at the uterus here, another look, and we got a good biopsy of it, and turned out she had a leiomyoma in her uterus. And we talked about removing it, but they never elected to do that. But this was a great opportunity to do a standing laparoscopic procedure in a megavertebrate. So that was an exciting time. How not to treat your equipment. We realized that we were struggling getting to the areas we needed to get to at the instrument lengths that we had. So I was actually using this 50 centimeter cannula to help lift up some bowel, and ended up bending it, but it didn't break. So at least that was a good sign. With that though, we came up with a plan, how to move forward and what to do. And with that plan included more instrumentation and double walled cannulas with long pyramidal shape, the obturators on them. And we really were very fortunate. And so I'm grateful to be able to give back a little to the Storrs endoscopy talks because of all the support that we've had in getting instrumentation that we need. So that was the beginning for me. And with that, and the first, as far as we knew, successful standing laparoscopic approach on a megavertebrate, we then moved on to elephants. And I think some of you might have heard Mark Stetter's talk on elephants, so I won't belabor this a lot, but just to give you some information as to help you understand some of our next steps and where we went. So for me, the next step was the elephant laparoscopic vasectomy. And why do we do those? Well, elephants are amazing, but in Southern Africa, there are more of them than we know what to do with. They do a lot of damage to the trees. This is a 70-year-old acacia tree that it took this bull a couple minutes to knock over. This is another thing, they debark the trees, and so that kills them, and eventually turns into places that look like this, which is one of the national parks in Swaziland. And the idea was if we could vasectomize the dominant bulls, we could minimize population growth. So this is what the land looked like where the elephants are in the national park. And this is the park next door, which doesn't have any elephants. And you can get a good appreciation for what the devastation to the habitat is. So my first question is, why would we do laparoscopic approaches to do a vasectomy? And I was quickly reminded of something that I probably actually never knew, which was that elephants have intra-abdominal testes. So this is a beautiful elephant bronze just outside of the Kruger Elephant Museum. And what I did is superimpose the skeleton over the top of this elephant bronze. And what we see is that the kidney here is, the testis is just behind the kidney, with about a 1 meter long epididymis slash vas deferens in these guys. And so there is no way to make an approach to them without doing an abdominal approach, and certainly doing them laparoscopically seem to make a lot more sense than otherwise. This is what it looks like endoscopically. So here you see the testis. This is the vas deferens as it runs down in the mesoductus. Removing a segment of that looks like this, and then on histopath looks here. So the big thing probably to think about as we do this is that minimally invasive equipment needs to be fairly sturdy to make trips like this. And we've did a number of those trips. And this is where we're getting everything set up, getting ready to do the procedure, checking everything out. We learned a valuable lesson on one of our trips that you really need to hook everything up and test it once you arrive, because sometimes there are some difficulties in getting these animals or getting the equipment over there or through the airline. So we're setting it up. We do gas sterilization in these big SKB cases. This one happens to be a piano case. This is a gun case. And we've got instruments in here. We've got drapes and other things, a couple of different packs. And then here's Christopher. Now, Christopher was a great model for demonstrating this scope. To give you some specifics, it has a 98 centimeter working length. It is an operating scope, so it has a right angle objective and a 10 millimeter internal chamber. It's about 3 centimeters in diameter, has 2 light sources or light channels, and the lens channel and an instrument channel, and then this very long cannula that goes with it. Our instruments are anywhere between 1 meter and 1.4 meters long, so that we can get in and work within the abdomen. Insufflators look a lot like an air compressor there, because we don't use carbon dioxide in the bush. It's a little bit too challenging, and the volume of air that we use is a little bit much for using tanks. So we use an air compressor. We put everything in a rhino crate. In this case, we've got a big generator. All of our equipment here sits on top of this crane truck. Crane truck goes out to the bush. The helicopter goes up, darts the elephant. We drop the crate off one side and start setting up our surgical theater while the anesthesia team works on the other side. In this case here, Jeff Zuba doing the intubating, sticking his arm down into the mouth and then a long tube and passing an endotracheal tube over the top of that. There's the team getting ready, getting catheters in the ears and taking measurements and getting all the things done. And then the surgery team working together to get everything ready to go. So we'll put sterile drapes on tables and start opening equipment and then lift those tables up onto the crane truck. Finding the position is challenging. Elephants' ribs go all the way back in their paralumbar fossa, so we have to go below the last ribs, and we use long spinal needles, 5-inch spinal needles, in order to sort out where the ribs are and make an idea of where our incision goes. We always joke the best way to tell where the incision is supposed to be is where this strap on the hind leg ends up. So we have to pull the strap back to get access to the paralumbar fossa. So here we are. This is just before we pull that back. We're getting the elephant stabilized, catheters in the ear, endotracheal tube in, everything supporting. We're starting to set up things on the back of the crane truck. Again, intubate, use oxygen to ventilate them, long endotracheal tubes in order to make that work. Lots of catheters. We've got intravenous catheters. We've got intraarterial catheters in order to provide sedation via atorphine and be able to monitor these cases. We monitor all sorts of things, blood pressure in these cases. We can measure end-tidal CO2, and we can monitor all sorts of things. And then this is what the surgery side looks like. So again, a generator to create electricity, an air compressor to give us air. We run that air compressor through a two-stage filter system into a homemade insufflator. We realized that the traditional insufflator just wouldn't give us enough pressure or flow in the abdomen to work. So I made this one in the garage using an oxygen and acetylene regulator, putting in then a backflow measure or gauge here to tell what the intra-abdominal pressure is. And then we run everything through a microfilter before it goes into the abdomen. So macrofilter, microfilter, and then we use bush air to accomplish this. The first time we tried this was with a regular insufflator, and we didn't make things work. So we built this the next time, brought it back, and things worked very well. But I put a PSI gauge, so pounds per square inch, instead of a millimeter of mercury gauge on it because it was much more available to me at that point. And the big thing that we were talking about is we're at a PSI of 1, which brings you to actually about 52 millimeters of mercury. So we tried to stay about a half PSI, which would keep us in the 25 range. And we were fairly successful to get some visibility. And sometimes we'd have to turn it up a little bit higher, but we could then bring it back down fairly quickly. And we jokingly didn't tell Zuba what we were doing with these pressures. And he was very pleased with 1, 2, or 3 instead of 12, 20, and so forth from a millimeters of mercury perspective. But it worked very well, and everything went fine with that. So here we are showing the some video. This is removing a section of the vas deferens in this case. So we're going to remove a section of that. There it is removed. And now I'm going to show you a couple of other still photos of other abdomens. So now the other side testis and the vas deferens here, a smaller testis and the vas deferens coming on this side. Again, another one. This one had a very visible vas deferens. This was great as long as these guys were fairly thin. And the heavier elephants, it became much more difficult because there would be a lot of fat in this area, and it was a little more challenging to find the vas deferens. But the beauty of minimally invasive surgery is we got to look at this that you're never going to get through a regular approach. In fact, as we tried this on one of the early elephants, was to just reach in and try to bring the vas deferens out to the flank, and it wasn't possible to do. And then the other thing that's really amazing is this is what it looks like a few minutes after surgery. So here's one of the bulls. This is 5 minutes after reversal. We've just done a bilateral laparoscopic vasectomy on him. And he heads off into the bush. And this is good because we're not able to monitor him other than remotely. So it's a great opportunity to be able to do this. We've done around 50 animals and had great success with getting these guys right back up on their feet and back into the bush. Cleaning between procedures, the other nice part about this is it's become relatively quick. We can do a surgery in under an hour, and then we can clean instruments and move on to the next bowl. So we've got things ready. As soon as we're done with certain pieces of equipment in surgery, we hand those off to the cleaning team to get them cleaned up and ready for the next one, and then we cold sterilize everything before we move to the next elephant. We can do up to 3 elephants a day. We're typically there in their winter, which makes it a little more challenging to be able to get more done because it gets dark too early. Here's our biggest bull that we did. You can see he's a lot of elephant, and then our littlest one as well. I will honestly tell you that these little guys are very easy to do. The big ones are a little bit more challenging for sure. And with that, I'd like to take a space and see if I could answer any questions.
Yeah, Dean, we've got a couple of questions. One is, what do you do for hemostasis? You know, when you resect the vas deferens, do you have to do anything at all?
That's a great question. We do not have to do anything for hemostasis on those. There's a little bit of bleeding for sure, but it's actually quite limited. There's a pretty large vein close to it, and we've learned where that is. Fortunately, when we first went, we were there with elephants that had very little intra-abdominal fat, and we could see that, so we know what to stay away from. If we hit that, life might get a lot more interesting. We tried bipolar forceps on these, but they're just too long. We aren't able to get enough energy to the end of the bipolar forceps with a 1.4 meter long instrument to do any sort of coagulation.
Okay. And then there was a question, is using the compressed air, is there any issues with using compressed air rather than an air compressor?
Yeah, so good question. We did the air compressor because it was simple and straightforward. We did a little looking, and on the human side with notes, they typically use compressed air as well instead of the sterile CO2. And they've had great success with that with very limited, with actually really no problems whatsoever. So we decided that bush air would probably be a functional way for us to accomplish this. And it has worked very well.
And another question is, how many vasectomies have you done in the field so far?
We've done just short of 50. I think we're at 49.
Wow, that's a lot. One other question, when you showed your picture of the scope and the cannula, it looked like, at least in small animals, we have what we call an endotip that just twists in, not requiring a trocar. Is that what that was? And does it get easily through the peritoneum?
Yes, so that's a great question. My favorite time of all was the first time we went over, and that is an endotip cannula, and designed just like you would for a small animal equine. And it's got the two long handles on it. And I actually put that in the abdomen, the first elephant that we did, and started turning it in, and it just got tighter and tighter and tighter as it hit the peritoneum. Finally, I couldn't go any further. And when I let go, it untwisted. So no, it won't go through the peritoneum. We actually have to cut through that with scissors. So get the cannula in and then cut through it with scissors.
Okay. I think that's all the questions we have for now. So I'll turn it back to you.
Wonderful. So what do we do from there? So we learned that, one, we can do a standing laparoscopy on a rhinoceros and get a uterine biopsy. That led for us to go to Africa and do free-ranging bull elephant vasectomies. But what else could we do? And that's where we brought things back and started looking at some of our animals here in the US and saying, well, how can we use these techniques to help these animals out? This happened to be a cow elephant at Disney's Animal Kingdom, and she just hadn't been doing well. Fevers, blood work showed an infection somewhere. They couldn't find anything else, thought that it was likely in her peritoneal cavity. So why not go in and have a look? So we did the same thing. You can see now we've done her standing sedated, though. We don't have her hanging from a crane truck. We put the spinal needles in to identify her place, made our approach in, and turned out that she had a peritonitis. But we were able to do a really good directed abdominal lavage, and she did much better after that. And so I think what we learned was that now we can start bringing this back in, looking at some of our zoological animals. Then the San Diego Wild Animal Park, or the Safari Park at the time, called us and said, hey, we've got a couple of rhinos, one northern white and one white, or southern white, and we'd like to harvest ovarian tissue so that we might be able to do some advanced reproductive techniques in these animals. Would you be willing to come give us a hand? And so we went to try to do that. And so here's one of them, the northern white. And these guys had not been reproductively sound for years. And so there was no concern that we were going to cause or reduce the chances of them having babies. We just wanted to see whether we could harvest ovarian tissue. And so this northern white had been pregnant, but had not cycled after this at all. And so they decided she would be a good one to work with. And we were able to go in and help with her. So we got her down on the ground. And then we set up a little pavilion because it was a really sunny day. And that's one of the downsides of doing the large exotic animal stuff outdoors, is that the sun plays havoc on the monitors and makes it quite difficult for us to see what we're doing. But we put the sunshade over, and we went in and did a laparoscopic exploratory on her and identified her ovary. But what was very interesting with her is that why she had stopped being reproductively sound is that at one point when she was pregnant, she had resorbed most of the fetus but mummified the rest. And that had caused some significant problems with her ovaries and oviduct. But we harvested the ovary, and they were able to do some advanced reproductive techniques on that. So here we are doing the procedure, again, fairly standard. She was not amendable to be done standing, had to be anesthetized to work with. But there she is, just shortly after surgery, with a small incision here in her flank, and she is up and going and ready to go. Then we worked on one of the southern whites, who was also out in the exhibit and not terribly pleasant. So here, as you can see, the dart up here in her neck. And we're trying to get her into a spot where we can limit her mobility and start to notice the vehicles here. And she is not kind. Almost all of these dents have come from her. And I was laughing because Zuba said, hey, if you want, you can sit by the window. And I'm like, sweet, I always want to sit by the window to see what's going on. But when she walked up there and almost stuck her horn through the door in the window, I was seeing why he was letting me sit by it and not in the middle. So here we are, you can see there's quite a bit of dents. Those are mostly her handiwork. But this is what the team looked like. It was a bit of a cloudy day, so we were able to actually get her taken care of without the sunshade. And we're able to go ahead and do the exploratory and also get an ovary from her for some advanced reproductive work. Nice cloudy day, made it work well for her being in the shade and for us. So a lot of what we have done minimally invasively from the elephants was to stop reproduction, but now we're working with the rhinos to see what we can do to help reproduction. So those are the abdominal approaches that we've done, but I just want to encourage you that there's a lot of reason to use rigid endoscopy. In this case now, we're part of a team that's working on the northern white rhino recovery. And what they're trying to do is use some southern white rhinos to practice a bunch of assisted reproductive techniques and then harvest eggs from northern white rhinos and implant them into the southern white rhinos. But they had some questions about what was going on reproductively and asked me to come out and help them see what's happening with the vagina and the cervix. And so we were out there, Dr. Pezzanite here in the near ground. I was one of our residents at the time. She's now doing a PhD with us, and then a bunch of folks from San Diego. So we have these guys in these stocks. They're trained now to be in these under some sedation, and we're able to go in and do some work. So here's a little video. In this case, we're using the long equine scope and the telepac, and we're doing a vaginal exam. It turned out both of these animals actually have some very interesting and strange vaginal anatomy that we're still trying to sort out exactly what that is, but it worked really well. It's a great use for this telepac. It's got great light to it, and we're able to see what we're doing and work through that. And this rhino actually had a septum that was a vertical septum in her vagina, just in front of the persistent hymen. And so we were just sorting that out. So here you look, this is what it looks like inside. We're starting to insufflate the vaginal vault here, so you can see the normal ruga of the vagina. And pretty soon you can see that the strip of tissue coming back and forth in between. And this is a vertical septum in the vagina of this rhino. And it turned out that of the 6 that they had, I think 3 of them had these vertical septa. You can just see the cervix just up in the front. And so we realized that these were a problem and were going to be an issue for breeding and other things. And we were able to go in and resect those vertical septa and help these guys out. Then we had another one, though, that wasn't very amenable to standing stuff. And she had what seemed like a very strange structure in her vagina. So we went out and looked at her another time. And it turned out that it was just a very thick, persistent hymen that we were able to break down and get her going again. But again, a nice use for the rigid endoscopy, giving us opportunities to look at things and see things that the flexible scope just didn't work quite as well for. Nice time to do the rigid endoscopy. So if we look from there, those were the common things that we did. We started with the big ones. But then some of the other groups started wondering, well, could we use some of these approaches for some of the other animals that we might work on? And that then began the look at some of the dolphin work. And so this was one of the first dolphin procedures that we did. This was a dolphin that had a renal nephrolithiasis, and she was out at the marine mammal system out in San Diego. So it's 31-year-old, chronic severe bilateral nephrolithiasis. She had occasional episodes, azotemia, hematuria, anorexia, gastritis, but a good quality of life by and large. And so for a long period of time, they just a couple times a day would give her couple of fresh liters of fresh water orally, and she did well with that. And then they did routine ultrasound, blood, and urine analysis. But then she started to not do as well. And they had the opportunity to do a lot of different things with her, going up to Balboa at the Navy medical facility. So they were able to do nuclear scintigraphy. and show that the one kidney here actually was pretty healthy and was looking pretty good. The other kidney was not very functional at all. They did CT on her, and you can see that the kidney that is not really very functional has hundreds of stones in it. The other kidney did not have any visible stones on CT, but did have one ureteral stone. And so we felt that this was the problem. For a long time, they knew that this kidney was not doing well, but that it was okay because the other kidney was very functional. But now with this ureteral stone, that was a problem. So they looked again here. If you look at the 3D reconstruction, the one ovary with all the stones in it, there were some other stones in this one. They just weren't showing up very well in this one on the CT, and then the one ureteral stone down here. They said, let's do surgery. Let's see if we can put the scope in and help out. So my job as the veterinarian was to provide the naval urinary surgeons or urologists to access to the ureter. And so that was the goal. I went to find that, so we put the dolphin on her side, just a little bit rotated, and then we used ultrasound to start identifying different structures, determined that this was going to be the best place to go in and make the approach. This was the back of the kidney here, and what we could see of the ureter coming here. So our approach was going to be at this place between the aponeuroses of the rectus abdominis muscle. And it was a great procedure. We had some challenges. She was pretty sick by this time. And so the insufflation, and then we had some flexible scope problems with that. But we were able to identify the kidney, we were able to identify the ureter, but unfortunately the dolphin arrested under surgery and we lost the dolphin. But we gained some good valuable information. And here's what they saw in postmortem. Again, the very atrophied kidney with lots and lots of stones, the other kidney with a few stones, and then this offending ureteral stone here. But with that, we've now done some more laparoscopy on these dolphins, and we're getting more and more understanding of the anatomy, better understanding of what goes on with them, and how we can approach them, and what some of our techniques should be. Their abdominal cavity is long and narrow, and their hypodermis is thick and challenging to suture. But there is actually relatively good mobility with the scope, and you can, with the scope placed well, you can actually explore the entirety of the abdomen. And we're currently working on some techniques to do castrations on these dolphins as well. So lots of things that we can do and work on as we move forward. So from our time with Pokey, we moved to Africa, then we came back to the States and stayed with megavertebrates for a while, and then started playing with the marine mammals. And now I'd love to answer some more questions for you.
There are a couple of questions. One is, when you're doing your rhino vaginoscopy, how do you insufflate the vagina? Is that with saline or air or whatever?
Yeah, good question. We insufflate with air. So we just have a pump there to produce some air in there. So what I do typically is put my hand in and use that as a stopper in the vulva, and then put the scope, between my thumb and palm and into there, and then we're able to insufflate through that. So typically a cannula that goes in, then the scope, and then insufflate through the cannula with air.
Okay. And then a question about the dolphins. Do you know the stone type in this? And is this a common problem in dolphins, either wild or the captive? Do you know?
So I do not know the stone type. I did at one point, and I just don't remember. Sorry about that. And it is common in the captive dolphins. And they think it has something to do with the food source. And they're doing a ton of work on these right now, trying to look at what maybe they can do from a nutrition side to minimize the stones and why they are forming in these guys. But it does not seem to be a very big issue in wild dolphins. So they've done a lot of work on the stranded dolphins and the beach dolphins to look at them, and it hasn't been something they've noticed to be a big issue. So it seems to be associated with captivity.
Yeah. And then one final question. working with the MD urologist, a lot of times they do flexible cystoscopy and then cannulate the ureters. Was that even a consideration in this dolphin for that one stone?
It was, and they tried the first time to do that, but they were unable to get to the bladder. And so that's
Okay.
why we decided to do her laparoscopically. So what we did was a laparoscopic approach to the ureter, and then they used their flexible scope to go into the ureter from there. But they weren't able to get to the bladder through the urethra.
Okay. I guess that's the questions for now.
All right. So as we jump from the marine mammals, come back to some more terrestrial beasts and looking at them. And it seemed like I had a run on lions for some reason, just a lot of opportunity to look at those. This is a male lion that we looked at in November of 2012, had signs of gastritis, vomiting, lethargy, and appetence. The blood work was unremarkable. There was some mineralization of the liver on abdominal radiographs. And they wanted to do an explorer, but this is a big boy, and he's trained for blood draws, but he's not trained to do much of anything else. And so the idea was, let's go ahead and put the scope in, and then we got a couple small incisions to evaluate him, and instead of any big incisions. So we did that. Here he is anesthetized. We put him on his back, and the good news is, because we were working on the liver, and his chest is so deep, he actually, all we had to do was insufflate, and we got a great look at his liver. And what he had was a lot of masses on the serosal surfaces, and we biopsied those, submitted them for histopath, and they were essentially peritoneal inclusion cysts, non-neoplastic. His hepatobiliary structures were thick and lots of dark fluid, but honestly, it's almost like we just relieved any evil spirits that were in the abdomen with the laparoscope, because he did great after surgery and never looked back. So we have no idea really what was wrong with him, but he did very nicely afterwards. Basically, all the stuff that was in the cyst and other things were a benign peritoneal mesothelioma. Another one, now this one has started showing some significant neurologic signs, and again, the liver values were elevated. Ultrasound looked normal. It couldn't come up with any other problems, so we decided to go in and do a liver biopsy to see if we could understand why he was having the neurologic symptoms. And when we went in, he had a hugely distended biliary system. So unlike the last one that was very thick and walled, this was just balloons of biliary tissue here. And the liver was some parts looked fairly normal, other parts were very blunted. We went in and actually aspirated the biliary system, and I think we got over 200 mils of bile out of this, but it was basically normal. We did a liver biopsy, and we took a portion of the liver that was very rounded and thickened in him, and we went ahead and did a pretty straightforward biopsy. And this is again the beauty of minimally invasive, is that I think if we would have looked in parts of the liver, so if I'd have done a biopsy over here, it was actually fairly normal, but this gave us some answers. We were able to look and direct where we were going to and understand what was happening. And again, very nice biopsy. Everything looked clean. We were able to watch it later for any type of bleeding. There was a little bit, so we just took up monopolar cautery to this and cauterized a couple of the spots that were bleeding. He had diffuse cholangiohepatitis in the biopsy, and eventually he didn't get better, and they euthanized him, and he had hydrocephalus, and that was probably a congenital problem. He just got to the point where it was now a big enough issue for him that he had to deal with it. So good answers, and the nice part is within a day or two, he was back out on exhibit in the pen with minimal abnormalities, because he just had a couple small incisions. We had a P horse, or a Przewalski horse, that was down at the Denver Zoo that was not doing well, had some significant problems. So we brought her up and into the hospital and did a laparoscopy on her as well. She has a very interesting lesions in her duodenum. So the duodenum here, we're working on the right side because that was the part that looked the most abnormal on ultrasound. She had all these areas of diverticulosis in her duodenum, and again, probably a congenital problem. In there, we were able to go in and harvest some fluid of those with a percutaneous aspiration, lifting up the diverticulum to the needle going through the skin, isolating that, able to culture that and get a diagnosis. And so unfortunately, she just never got any better. And this was in a location that was going to be difficult to resect. And they just didn't think she'd tolerate a resection anastomosis. And so she was euthanized. But the nice part was we got good information and we were able to really give them some guidance as far as what was going on. Then I got a call from SeaWorld in San Diego, and they said, look, we've got polar bears and we tried breeding them, but we don't really understand what's going on with the ovary. And we don't think anybody's ever knowingly seen an ovary on ultrasound on the polar bear. Would you come in and find the ovaries with the laparoscope and show them to us and let us ultrasound them through the body wall? And I thought, well, that seems like a very reasonable plan. So we thought we'd do that. And I took a page out of the small animal surgeon's book. And we put her in a 45-degree angle to do this, with the idea being that we could then rotate her to the opposite side if we needed to in order to see the other ovary. So we've got some poles up here on the table that her legs are attached to, pole over here that her leg is attached to, and then we're going to go in right on midline and do our approach. So instead of a more traditional equine approach with an umbilical scope and then inguinal approaches with the instrument, we're going to keep everything right on the midline. So that was the idea. Here we are all draped up. We've got the scope in one hand and the instrument holding the ovary up, and then the ultrasound probe coming in the side under the drape. So the ultrasound probe, you can just see somebody's hand right here. And they're going to push the probe down for us to see what we're doing. And this is what it looked like inside. So here's the left ovary. So she's in right lateral recumbency, the left uterine horn, some small intestine. Moving up, there is the left kidney, left spleen, or actually the spleen, greater curvature of the stomach, liver, diaphragm. And then we're going to come back and look at the ovary, and the ovary is encased in a bursa of fat. And the reason why it's so difficult to see the ovary or know what you're seeing on the ovary on these guys is because it looks very much like fat. And so here we are lifting the ovary up. We're going to rotate it over. And now you can see the ultrasound probe pushing down here, ovary there. And we're actually able to do ultrasound of the ovaries so that they can get an idea. So we come down the horn and look at the bifurcation here. We can see easily that we can come along and find the right uterine horn as well. So colon is up here, bladder is back there. And we're going to lift up the left uterine horn. And then we'll follow the right uterine horn down to the right ovary in order to bring that right ovary up and actually ultrasound it as well. So there's the right ovary, and you can see how much fat is around these, how much fat is in the abdomen of this polar bear, and that's why it was very difficult to distinguish that they were looking at ovaries. To give you a perspective, this is the ovary being held up to the body wall, being ultrasounded here, and this is what the ovary looked like on ultrasound. So not that different from the fat tissues around there, unless you can see this follicle. So they got a nice follicle, and unless they have a large follicle, the ovaries are very indistinguishable. But minimally invasive surgery allowed us to really come in and figure out how to see this and do this. And now that they know what they're looking for and where they're looking, they're able to do these ultrasounds now percutaneously without doing the minimally invasive approach as well. Another example of an Asiatic black bear that we did a liver biopsy and an exploratory on, and this is within minutes back in the exhibit. It worked very well. Ostrich that we looked at, and this is the visual of that, and there were just adhesions after adhesions after adhesions in the coelom in this ostrich. It turned out she had lymphosarcoma throughout the entirety of her abdomen. And just to give you an idea, again, we were able to go in and diagnose this that they couldn't do otherwise. And the laparoscope gave us a great visibility, well, within reason, because you really couldn't look around much because of all of the adhesions that were found in this abdomen. So good opportunities to go in and have a look at things and just to prove that it's not all about large animals. This is a mandrill that I did a tubal ligation on. They wanted her to stay in the exhibit, maintain her cycles and her estrogen and consequently the hierarchy, but they didn't want her to breed. And so we went in laparoscopically and did a tubal ligation. And I think this is, again, one of the nice parts about doing minimally invasive surgery now versus 25 years ago when I first got started in these things is the equipment that we're able to use. So to pop down to the zoo, I've got my telepack with my little cart and an insufflator. It all fits in the back seat of my pickup. And I can run down to the zoo and do a laparoscopy pretty quickly and pretty easily. And then here's probably the smallest patient I've worked on is this capuchin monkey that had an ovarian cyst that they decided that we would do an ovariectomy on her to get rid of that cyst, and we were able to do that. So I actually had to borrow some 5mm equipment for her because I realized that the long equine stuff that I had probably wasn't going to work very effectively in this little bitty thing, and it worked very nicely. Again, the beauty is this, after the surgery was done, the next day she could go out onto exhibit. Where do we go from here? Well, maybe the next big thing that we do is to train some Colombian veterinarians how to do vasectomies in hippos. So many of you may be aware that Pablo Escobar had a bit of a zoo when he was there, and the reports vary, but either from, as he knew he was going to be caught and taken into custody, he turned everything loose, or somebody else turned them loose. I don't know, but he had some hippos, and they have done very well down in Colombia. But the people don't really know how to live with hippos in Colombia like they do in Africa. So that becomes a bit of an issue. There are over 100 of them now. And the idea is to do potentially vasectomies, which that was just a video of doing a vasectomy and a hippo cadaver, or ovariectomies. And so we're in discussions now to talk about how we might do that and what we might be able to offer them. So as we wrap things up, just in summary, I think this is how I put it to people, that large exotic animal surgery, especially minimally invasive, is demanding, challenging, rewarding, and fun. I think it's great. We have opportunities now to provide options for these animals that we just haven't had in the past. And we're getting to do more and more things, and we're finding more and more things, and we're learning more about their anatomy and things that we can do to help them out. Success is possible, but challenging because we don't get to do these a lot. And I think that probably becomes the biggest reason you have to be a good translator to do that. We don't get to do very many of these. And so you have to take what you know with doing the other things that you do and translate it into these animals that you're working on. The other thing is what we bring as surgeon, I think, encourage us all. We bring a small subset of expertise into the surgical theater. And we need to remember that. The exotic veterinarians or exotic animal veterinarians that I work with can sometimes feel they're pretty hesitant to want to work with us because we might come with a bit of an attitude as surgeons into this field. And we need to recognize that we bring a small piece of this whole thing. There's a big team that works here to make them anesthetized and to recover them and take care of them. We do a small part of the procedure. And then our job is to translate. So I've learned how to take what I do on a regular basis with the horse and translate it into a number of other species that I've been able to put a laparoscope in and try to figure out what to do. And looking at ways to train and practice can be challenging, but there are opportunities to do that. So I think if you can become a good translator and a good team member, you find yourself doing a lot of things and working on animals in a lot of different places. And with that, I would like to take whatever other questions you might have.
Well, Dean, in this last section, we don't have any questions, but I guess I can pose a question to you. One is, looking at those lions, I was really fascinated in the fact that you saw these lions with cysts in the liver and cholangiohepatitis, and that's what we see in cats. And the cysts in the liver, we now know is a congenital defect in bile duct development, and cholangiohepatitis is the most common liver disease that we see. So there's a lot of translational stuff that we can that we see in our animals, domestic animals, that you can translate over into your wild and exotic animals. I think you need to take an internal medicine person with you, though, on some of these liver biopsies.
Yes. Oh man, I gotta tell you, I'm pretty sure that first line when I was looking around, I was wishing you were on my shoulder for sure.
Yeah.
And I think you make a really good point there, Dave, is that we actually have a great bit of knowledge and information on working with these guys, with animals like them. And I think that's why a lot of this has worked well. And there's opportunities for us to really take that knowledge we currently have and use it to help these animals out. So I think that collaboration is really important.
We also got one more last question, and that is, have you done any seals, and are they similar to dogs?
I have not done any. I have not. I've not done any seals. I do know people have done some work on sea lions, and they do describe that their abdominal contents and anatomy is similar to dogs. So I would imagine seals would be close, but I don't know the answer.
Okay. And I guess we have one more, and that is, what are your next steps in the evolution of what you see in MIS procedures in exotic animals?
Oh, I think there's so many different places that we could go. I think honestly, a big one will be looking at dolphin castrations and looking at ways to have dolphins that are doing their job for the military, but they don't want them to be aggressive. They want them to be able to go find things for them. I think that's going to be a big thing, looking at that. We're going to continue to see more and more evolution of getting into these guys' abdomens more quickly. That's probably the biggest thing. So my last trip out to work with the Navy, we had a dolphin with an outflow obstruction of her stomach. And when we went in, it turned out that she just had a very proliferative disease of her pyloric antrum, and it had just reduced it down to nothing. And there was just no good way to resect it at that point. But I think that there might have been a time where we could have done something for her. And as one of the staunch folks from the Navy was standing in the background, who had been kind of poo-pooing the idea of doing laparoscopy, looked at it and he said, wow, he can see stuff in here we've never seen before. We need to get better at diagnosing so that he can take care of them earlier. And I think that's what we need. What we need to do is get into some of these guys before it's nearly too late, because it's not very fun to be the one to push them over the edge.
Okay, Dean. Well, thank you so much for your presentation. We really appreciate you contributing to our Endoscopy Talks program. And I want to thank all the audience for joining us. And again, his webinar can be seen, it's recorded and can be seen at any time at endoscopytalks.com. In 2 weeks, we'll learn about laparoscopic assisted splenectomy. This is presented by Dr. Nicole Biot. She's from Cornell University. And that session will take place April 7th at 8 p.m. That's New York time. And so we look forward to seeing you then. And in the meantime, we're wishing the best of health to everyone. So thank you. Hi, I'm Dave Tweed here at Colorado State University's Translational Medicine Institute, inviting you to attend our hands-on continuing education course entitled Introduction to Small Animal Laparoscopy. I started doing laparoscopy many years ago using an old rigid human proctoscope to perform liver biopsies. We have come a long way since then, and now have the state-of-the-art laparoscopes and laparoscopic instruments. If you want to learn minimally invasive techniques to obtain diagnostic organ biopsy, or want to begin performing basic laparoscopic surgical procedures, then this is the course for you. I will be teaching this course with Dr. Eric Monet. He is one of the premier laparoscopic surgeons in the world. Recently, Dr. Monet performed a laparoscopic cholecystectomy on my own dog that had a mucocele and had the gallbladder out in 30 minutes, and my dog was normal the next day. Now, you may not be Dr. Monet after this course, but you will be able to go back to your practice and do organ biopsy and perform basic laparoscopic surgical procedures, such as an ovariectomy, full-thickness intestinal biopsies, and prophylactic gastropexies. Laboratory groups are small, so you will have lots of hands-on experience. You will practice first using simulated trainers and then perform procedures on cadaver specimens. You can also register for our 2 advanced courses teaching laparoscopic ovariectomy and gastropexy, where you will perform the procedures on rescue dogs that were to have surgery using the more invasive traditional techniques. To get more information or register for this course or other courses that I teach, simply go to www.csuvetce.com.